Yeah.
So you want me to share?
Yes, please.
Okay, just give me a second. So again, this case, is I have not seen the patient. I've only spoken to the patient's caregiver, so to say. So, but I still thought it's worth talking about it. Can everybody see it now?
Yes, we can see. I can see it.
Let me just put it on a slideshow. Okay.
Yes, perfect.
So, right. So this, the patient is a 56-year-old lady diagnosed about 3 years back with a progressive motor neuron disease, ALS. And currently she is admitted in the hospital. She was admitted, this is last week, she was admitted to the hospital because she was unable to swallow. That was their main issue, that she's not able to eat anything. And there were, along with that, there were thick secretions in the mouth, and she had bouts of cough at times, which would be non-stop when it started. And she has severe pain at multiple sites, no one specific site. In general, she has pain at a lot of places. So she used to be very active 3 years back, and gradually she has now stopped doing everything. She is bedridden, and her family is obviously worried because of that. So currently she has also lost a lot of weight because she is not eating anything, her families, and she is unable to breathe now. So at the hospital, they put her on oxygen. Oxygen saturation on admission was 34%, but currently it is normal with BiPAP. Other vitals are stable, and her pain score, when asked, she said it was about 9 on 10. So treatment she's being, I don't have the dosages for this because I wasn't able to get this information, but she's on steroids, hydrocortisone. She's been given noradrenaline because her BP was very low, Duolin and Budecort by nebulizer, Pantocid, Augmentin, DNS and ringers, and Gabivenperi. I wasn't sure what this was, but this is being given to her for nutrition. Okay. Now, she's unable to swallow, but I think they tried to put in a Ryle's tube, and that was not successful. So after that, the patient and the family are very apprehensive, and they have not tried again. The hospital, they also considered a gastrostomy, but the patient does not want any sort of an intervention anymore. She's kind of tired of everything. She is telling them not to do anything more to her. So family is mainly concerned about her nutrition, that she's losing weight, and worried about how to give her pain relief. So if you notice, except for the steroids, which were not actually being given to her for pain. In fact, the patient's daughter, she's herself a dentist, she told me that nobody even actually asked the patient about pain. Nobody has asked her if she's having any pain. So main concern, like we already discussed, is pain, nutrition, and the oral thick secretions. So these are the discussion points. I did advise her to the best of my capability, but I've also told her that I will speak to everybody here and get back to her with, in case, I'm wrong somewhere or if something else can be done for her. So main thing is, if they're not able to put in a Ryle's tube, can the nutrition and pain relief be addressed via a subcutaneous route? Right? And just give me a second here. I'm not able to see. Right. So, I mean, should we just have the discussion with every question, or would you want me to go through all the points first? Dr. Sangamitra?
Yeah, you can go through all the points. No, not an issue.
Okay. So the second thing was that, because of the thick secretions, she was getting only Budecort and the Duolin inhaler, but she was not being given any mucolytic. So I was wondering if, something like that, Mucinex, she cannot take it. She doesn't have a rice tube, so they can't give it through that. But I read that N-acetylcysteine can be given via nebulizer. I don't know if it is given here. I just read about it. So I want everybody's opinion on that also, that can it be given via nebulizer? And currently, while she's not, while she doesn't have the rice tube, and once maybe if they get her to accept the rice tube and they're successful, maybe it can be given through them. I personally don't know. I need help there. And as far as pain management goes, obviously, they're probably going to stop the hydrocortisone. So I'm sure pain is going to come back. With a much severe form. So she has both nociceptive as well as neuropathic pain. So I discussed this with her daughter, and I asked her what kind of pain it is. So she has both nociceptive and neuropathic, and they have no access to morphine there. So I was wondering, since we discussed last, Dr. Sangamitra, you told us about tapentolol. I was wondering if she can be given tapentolol or tramadol in this case, along with paracetamol and a pregabalin maybe for the neuropathic pain. And oral care, I suggested that, they're not doing any sort of oral care. But when I asked her, she did say that there is a little bit of foul smell, though she doesn't have any open wounds or anything like that. So I just asked them to try to clean with soda bicarb using a gauze, because she's not able to really open her mouth. So she cannot rinse, but they can definitely clean it using a gauze. And then I suggested to start some passive exercises, because this is not something they're doing. The last hospital they visited, and they visited a few hospitals before that, while everywhere they've just sort of sent them off saying that nothing much can be done for her. So they're not even doing any exercises or anything. So this I suggested to them. And any other suggestions to sort of make her feel better? That's it.
Okay, that's one very important case actually. So I would like to invite Dr. Vinay and Dr. Mahesh. What are your takes on this particular case? Your concerns, if you could give Dr. Bijli some suggestions about these particular questions that she has raised. So after that, maybe we'll get on to the discussion.
Ma'am, how much pain has been reduced with this treatment?
So no, in spite of the treatment that she's getting, she says that her pain is 9 on 10.
In spite of pregabalin and
No. This has not been, she's not taken this yet. I'm thinking of suggesting this to her.
okay. Yeah.
She's only taking that hydrocortisone, which they're giving in the hospital. So they will be sending her home.
Okay, ma'am. She must be having one part is that fibromyalgia type of pain. As she's always lying down most of the time, so she must be having fibromyalgia type of pain, and pregabalin also work in that.
Okay.
Second point is about her calcium level. Because calcium, if it is in the higher side or it is in the lower side, both causes pain. And vitamin D, morphine, I don't think it will be helpful for her, because she must be having generalized body pain, and with paracetamol and pregabalin, that will be. And her kidney function, how that is working, that will help in deciding that type of pain.
As far as I know, her kidney functions are normal.
Then anti-inflammatory type of pain and bony, it might be. Since how long she was on bedridden?
She is how long totally bedridden? About a year.
She must be having osteoporotic type of problem also. And because of that, in turning, she might not be possible to turn herself.
Yes, yes.
These all will lead to pain, and it will be cured with pregabalin, one, and tramadol is also helpful, and with calcium level, that might be helpful for her.
Thank you. Yes, I should check with her. She didn't send this to me, and I also did not ask. Thank you. I will check this. Even, I mean, do you think there is any reason for calcium to be high here? It will probably be low, right? Any reason to expect a high calcium in this case?
Osteoporotic, it is the blood level may be high because osteoporosis.
Okay.
That may be one reason. But otherwise, normally it is lower side, and that is causing traction type of pain or stretching type of pain, because there is less flexibility in muscle when the calcium is less flexibility, and it is spasmodic type of pain. So, but otherwise, when there is osteoporosis in generalized body, and patient is not getting the vitamin D appropriately, that will lead to higher level in the blood and excretion of more calcium.
Right. So definitely I should advise her on a vitamin D and a calcium supplement also.
And she was for blood pressure, she was on that dobutamine or something. Noradrenaline.
I think when she was admitted, yes, blood pressure was very low.
That was in the infusion form.
Yeah, I don't have more details. She just said that when she was admitted, her BP was very low. So they gave noradrenaline.
And then one thing is that the lower calcium level may be caused by the hydrocortisone also.
Yes.
That is one. It increases the osteoporosis.
Yes. But
and Budicort also leads to that potassium electrolyte imbalance. These all are causing electrolyte imbalance also. And
Budicort she is taking only by nebulizer.
That also causes sodium disturbance.
Hospital. Only one. This was only in the hospital. 1 week stay. That may not be enough.
That causes potassium, but that will lead to heart type of conduction block or arrhythmia type of problem. But continuously not on, that will lead to sodium imbalance.
But there was
sodium, might be.
There must have been in the beginning.
Sodium imbalance will lead to calcium imbalance also, because both are cation. So it will lead to imbalance of both.
Okay.
Oh, yeah, sorry.
Dr. Mahesh, your take on this.
Yes, ma'am. If you are thinking about the fibromyalgia, the duloxetine is very good drug. You can use duloxetine, 20 mg.
Okay.
Duloxetine is very good drug. And
this is once daily, is it? I don't know much.
Yes, ma'am.
This is once to be given once daily.
Yes, once daily or twice daily according to the need, but duloxetine is a drug of choice for fibromyalgia. Okay, and second thing, N-acetylcysteine can be taken this with nebulizer, no problem.
It can be given, no? Okay.
Yes, yes, chest physician are regularly using N-acetylcysteine with nebulizer.
Okay, great.
How it is given, sir? Acetylcysteine nebulization. We
Comes
crush
in a
the tablet.
solution, no?
Yes,
Good.
we can.
We are taking. Okay.
Oh, we have to crush it because I think in
We are having tablet of acetylcysteine,
hmm,
Mucinex, that is
Mucinex, right?
600 mg.
So what
So
you
that has to be crushed.
To be crushed, but like we normally we give it dissolved in water, right?
Yeah.
So here you.
How? That's why I'm asking how it
This
is
is
given in nebulization.
you can use the distilled water and put it this tablet. Okay, these are the efflorescent tablet. Okay,
Okay, okay, okay.
so the chest physician they are using regularly. Okay.
Okay, I think we
And,
lost Dr. Bijli. Dr. Bijli? Hello? I think we lost Dr. Bijli. Yes, I think she'll log in once again, and then we can start with the discussions. Okay. Okay, I think, yeah, Dr. Mahesh, please go ahead.
good evening, everyone. Next, please. So this is a case of 24-year male with cervical spine injury with quadriplegia. It's very unfortunate that patient had a history of trauma, and after that patient is quadriplegic. Next, please. So presenting complaints was unable to move arm and leg. There is a small movement in the right hand. Otherwise, the patient cannot move with his arm and legs, and multiple bed sore because of the bone weight. So there is a huge bed sore in the buttock area, approximately around 15 into 10 centimeter. Next, please. So patient is unable to move his leg and arm following cervical injury, multiple bed sore all over the body, like heel area, like buttock area, near the scapular region, and patient is tracheotomized during the cervical spine operation, and Ryle's tube insertion because of the some problem with the aspiration. Next, please. So examination, a large 10 into 15 centimeter bed sore at the buttock area, small sore at the heel and the back area. Otherwise, patient can swallow, no pain and over the right leg, and otherwise patient can the CBC and all hemogram and ESR is bit high, respiratory rate was okay, all CN this chest respiration and the chest examination is normal, S1 S2 heart. So everything this cardiological and everything is normal, but the main issue is the patient is quadriplegic. Next is, so this was the significant that patient has at the cervical spine injury 3 months back, and the patient was operated for cervical spine, and just after the operation patient had some movement in the lower limb and the arm, but after 15 days of operation, the patient is totally quadriplegic. Now only the right hand has some movement. Otherwise, all this left hand and the both legs are, the patient cannot move, and the patient has a history of spine operation. Next, please. So, patient unable to move the body parts and totally dependent on the family members. Even patient can swallow, but there is, he needs someone to uh, give the some bites or juices or food like that. Next, please. Local bed sore care. The patient attendants, our staff, they used to do daily that twice dressing over the buttock area, and riles to feeding is going on, and patient attendant, they need to learn the dressing every day. So that is the whole story. But now the main part is what we do with this patient. Next, please. There is any the patient attendance is, they are telling that body movement will return back or not. How can we improve the quality of life of the patient? Even though the passive exercise is going on, still the multiple bed sore, when we do dressing, every after 2-3 days we see that there is a some another sore over the dependent area, even though the patient is using that alpha bed. So what to do next? There is no much pain because touch sensation is only in right hand, bit of the touch sensation. Otherwise, there is no touch sensation and pain sensation. So summary: 24-year male with quadriplegia with multiple bed sore with dependent family on the family members.
Okay, so the main concerns are bedsore treatment, body movement, will it return back or not? And how can we improve the quality of life? So can we have inputs from everyone here? So I just want to know, how will you approach this patient? What kind of approach are you going to take? If I can have one point from each one of you, we can actually make up the whole case management of this patient. Dr. Bijli, you're not really audible actually.
Oh,
Hello?
yes. Can you hear me now?
Yes, we can hear you now. Yeah, go ahead. Please.
Can you mention, are you talking about like physical aspect or
Yeah,
psychological that way, right?
how will you generally approach this patient?
So I think something that would most concern this patient is the question about whether he is ever going to become all right. So I think that needs to be addressed first with a counseling to understand what his apprehensions are. I'm not sure that there is going to be really, there's probably not going to be a full recovery. If at all, some minimal recovery may take place in this case. So I think that would need to be addressed. And then, of course, the physical.
Okay. What physical problems do you see generally in this patient? What do you anticipate?
Circulation would be an issue since he's quadriplegic. Circulation is definitely an issue. He's going to continue to have so many bed sores also because of that. No, one has to maintain circulation somehow by maybe doing passive exercises and massage. All these things can be done to maintain that. And then mobility, though he's not able to actively make any movements, but we will need to try and prevent any disuse atrophy and contractures if
Right. Okay. All right. Dr. Vinay, can you give us some inputs?
Yes, ma'am. Our first concern in this type of patient is we can ask from the neurologist how much the recovery part, how much it is possible, and how much how is the prognosis of this disease. Second part is our main concern is to there should not be any bed sore development. For bed sore development, there are assessment risk, how much the patient sensory perception is, and moisture and activity, mobility, nutrition, and friction. These are the we can assess from these things how much the bed sore chances are there, and we have to prevent all these, as we have to prevent the moisture part of the dependent area, and there should be no friction between these area. Activity should be, as madam has already told, passive exercises, and nutrition, her nutrition should be it should be adequate or in quality wise it should be good with vitamins and all. And third part is that if there is sudden loss of the weight, then subcutaneous fat is lost, and there is more chances because of the friction shear forces, there is more chances of development of bad sores. So these are my. And what about the sensory perception? If the sensory perception is there, then there is good chances to prevent the. Otherwise, we have to turn the patient after in a same posture with others' help. Not, it should not be not more than 2 hours in the same posture, and moisture patient should be catheterized or other. He should be cleaned and moisture free, not catheterized actually, but he should be clean and moisture free, and nutrition should be adequate, and passive exercises.
Right. Anything else, Dr. Mahesh, you want to add to this?
Ma'am, actually, from the neurological side, it's already 2 months gone. So they want to see minimum for the 3 to 6 months for any other improvement. But
Okay.
chances are very less.
Okay. So let us understand one thing here. We are right now in the role of a palliative care physician. Okay. So here we will need to understand what are the present problems of this patient, number one. And secondly, what can we anticipate for, the future, where if the patient's condition remains the same. Regarding the neurological improvement, I think it will be much better for us to, keep that for the neurologist to decide, and maybe the the time will be a healing factor in that particular thing. But as of now, what are the main concerns that this patient have, which you've actually very nicely put in slides? And then how do we go about managing this patient, and then anticipate what might happen later on because of this? Right now, I see that the patient is a young patient, so he's definitely having a lot of psychosocial issues. So we need to manage the psychosocial issues. Secondly, the physical problems that is already there, and the physical problems that are going to happen, the anticipation that I'm talking about. So right now, he's quadriplegic, because of which he doesn't have any movement of the body, and that is why he's losing on his muscle mass. And as Dr. Mahesh rightly pointed out, there is a loss of subcutaneous fat, and hence the bony prominences would be actually, having a lot of friction with the other surface of the bed. And then that is going to cause a lot of, problems, and then lead to more of sores. And this has been actually happening since the last 2 months, since the time that he has been paralyzed. And because of that, there are already perhaps, grade 4 or non-gradable bed sores. So we'll need to manage bed sores. So we all know about bed sore management, how we do it. The main prime focus should always be, movement of the body, and every 2 hours. So this is a particular nursing concern, and if the patient, is in the hospital, then it's definitely the nursing team which comes into play, and of course, a doctor's, a palliative physician's orders to, keep on moving the patient from side to side, every 2 hours. And if the need be, then perhaps we'll have to take a opinion of the surgeon to, do a surgical debridement of the highly graded bed sores. That is one. Secondly, we are also concerned about, the patient not able to get his normal feeds. Okay. So as I can see, was there a Riles tube for this patient? Dr. Mahesh? Yes. Hello? Hello?
Yes, ma'am. He has told that he is swallowing reflexes were there, but he is still on rice tube.
Riles tube. Okay. So, so when the patient is on Riles tube, it means that, we will have to perhaps take care of the tube feeding also. So for our patients, we generally ask a feeding for 175 ml or 200 ml even every 2 hours, and that is only going to take care of the nutrition. Uh, Many would suggest a total parenteral nutrition sometimes, but if that is going to help this patient, then we should surely go for a total parenteral nutrition. There are other facets to this particular way of management or way of nutrition also, which we need to take care. Secondly, if since the patient is bedridden, what are we going to anticipate? What are the problems that might occur? One is definitely, we've already discussed about bed sores. Secondly, do we are we taking care of the constipation which is happening? Is there a problem of constipation? What about the urination? Is there catheter being fixed, or are the bowel movements normal? So I think those things need to be discussed at length, because if you see that the patient is constipated, you can actually, patient at one point of time, because of long-standing constipation, may land up in something called delirium also, which is quite common with bedridden patients. Unfortunately, they don't get advice of taking them out of the bed, taking them out into the garden also. They are there in that same particular room and the same particular bed for all these months, or even years. I've seen patients like that. So I think we need to anticipate on those lines. Those are very important. So take care of the feeding, take care of constipation, take care of the urination, take care of the bed sores, prevent bed sores from happening, from new bed sores from happening, and then comes the the physiotherapy part, which is also important, because in quadriplegia there is a loss of muscle mass, there is a loss of subcutaneous fat, and henceforth physiotherapy for this patient is very important. And even from the neurological point of view, many of such patients perhaps recover with long-term physiotherapy goals. So I think this particular patient needs a multidisciplinary approach for his management. And as far as the palliative physician's roles is concerned, is definitely the symptom control and the day-to-day activity management of this patient. So this is how I would actually approach this patient. Okay.
How much? How do you care for rice tube in these patients, and how do you give the feed? You have told that 175 ml.
Yes. So the patient must have had started with maybe a 50 ml of feeding, but then we need to increase that feed to around 200 or even 250 ml. Okay. So I have a call from my patient. Can you please hold on for a minute, everybody?
Yeah.
Don't mind? Yeah.
Take orally also,
Yes.
but um, he can take only the semi-solid one. Whenever he takes some liquid, so there is a Ryle's tube, and the patient so we used to give the liquid part from the Ryle's tube and the semi-solid part from the oral route. So now the main concern from the patient relatives, that is it remain the same as means for the whole life? That is the main problem, because he is a 24-year male and very young fellow. He is admitted in our hospital last probably more than 25 days, because our hospital has minimal amount of admission fees, only 20 rupees per day. So they are feeling better that patient is in hospital, so no problem.
So, sir, I missed the beginning of your presentation. Was this the result of an accident? What made him quadriplegic?
Yes, cervical spine injury.
Accident.
Yes. Quadriplegic, cervical spine injury, for which he had operated 3 months back, and after operation there was some movement of the lower limb and the right hand, but after 15 days the all movements, the patient was quadriplegic. So now only there is some movements in the right arm. Otherwise,
Hello, I'm so sorry. Actually, two of my patients are very critical, so they have been calling. Yeah. Okay, so yeah, so what was the discussion? Yes.
Ma'am, discussion is going on that the patient relatives, they want to ask that
Hello,
he, hello, are you hearing? Hello, my voice
am
is
I
clear?
audible?
Yes,
Yes, ma'am.
yes.
Hello.
Yes, sir, you are
Hello?
clear.
So relative, hello, Sangmitra ma'am, hello.
Yeah, am I audible now?
Yes, ma'am, yes.
Yes, yes.
Yes, yes, I can hear you now. Yeah, please go ahead.
So, ma'am, patient relative, they want to know that the patient uh, is it for whole life or patient will improve?
Okay, so what is your take on that? Do you think the patient is going to improve?
Very, very rarely, ma'am,
Very.
because
So, do you think it is important for us to tell the relatives or the family about this?
yes, ma'am, we told them that if anything, any movement will return back, it will return within 3 to 6 months. Otherwise, there will no hope.
Okay, and what was their reaction to this particular uh, bad news?
They already means that where the operation has been, that in Jaipur, the neurosurgeon already told that if it is gone, probably it will not come.
Okay,
Hmm.
okay. So, they are aware of this particular situation, right? And
Yes.
does the patient also know about this situation?
I don't know, ma'am.
Okay, so I think the patient also needs to know because he's a young patient, and there are lot of things which goes on in a mind of a young patient if the patient is paralyzed. I think he's 24 years, as you have mentioned, and on bed since the last 24 months. Sorry, 2 months. And then with all these physical problems, we can expect a whole load of psychological problems here. So if you have somebody in your in your team who's a counselor, uh, she can or he can actually talk to the patient about this. But before that, symptom control for this patient is very important. That is what is actually going to build a rapport with you. Once you control the symptoms, I think the patient starts having a more trust on you. The rapport is very well maintained, and the patient becomes a friend of yours. So and then he starts confiding all his plans or all his things with the doctor or the team. So it's very important that you do the symptom control on the first go itself. Do not let the patient suffer from more bed sores. That is the worst part that is happening to the patient. It's very important for us to um, realize the family that taking care of the patient is their primary concern. And when we start taking care, we actually involve a multidisciplinary approach, which we all talked about, the physiotherapy, the feeding part, taking care of the body, the bed sores, everything will come into that particular care. And when we take care of the patient generally improves, and that might give us a window where we can see some neurological improvement also. So until and unless we are sure about the terminal nature of a disease, for example, as in cancer, or in any kind of end stage disease, such patients live for quite a long time. And having said this, a lot of physiotherapy directed towards neurological improvement generally gives good results in the long run also. Or else, that is how we need to put this whole scenario. And sometimes, there is a caregiver stress. People, family might think, how long are we going to do this? And there's a feeling of guilt on the part of the family, on the part of the patient, that till how long, kab tak aisa chalega, kab tak karenge, kab kya karenge. So all these things will come in phases in such a patient's life and the family's life also. One particular caregiver, perhaps if the patient is married, it comes on the shoulder of the wife. If the patient is a old person, it comes on the son or the daughter, of course the old wife also. So it generally gives a lot of psychological burden and physical burden on the caregivers also. So perhaps we need to talk about things also, and address these concerns, make the family understand that these things are going to happen, or otherwise we might generally fail to care for such patients. There's a kind of loss of continuity of care of such patients. So I would generally approach a patient with quadriplegia in this manner. And then, my goals of care would be directed totally on symptom control and psychological issues. And then perhaps slowly, see the progress of the patient, and then perhaps change the goals as we go ahead. So that is how I'm going to do it. I don't know whether you agree with me in these points.
Excuse me,
Yes, yes.
ma'am, how should we tell this thing that he or she is not going to improve?
That is what you will need to, fall back on communication skills. It's a bad news, so you will need to communicate bad news in the same manner that we do, that you've actually gone through those modules of communication. You might as well have to do a lot of sittings, with the patient or the patient family also. And I'm sure the patient knows, for me, every patient is intelligent, whether this patient is a small child or a young adult or a very old person. So I generally take it for granted that all my patients are intelligent and they know their body much better than anybody else. And that is why they anticipate. It's only that, they live on a certain hope, which we must not shatter. And when I say hope, it is not unrealistic hope. It has to be realistic. So that is why we need to find out, what is the insight of that particular patient. So you perhaps need to fall back on your communication skills, go back to the spikes protocol, see how you can approach this patient, see how much, what the patient generally wants to know, whether or not the patient wants to know. That is an important question. So all these things clubbed together, you will have to have a holistic kind of a palliative care. I don't know whether I'm using this word properly or not. Yes, because you see, sometimes I too feel that I am a physician, I am a palliative care physician. So, my inclination towards physical symptom control is much more than, the psychological issues. I'm very honest with you. And that's why we'll perhaps need to do a holistic kind of a palliative care out here. So that might solve our problems and reduce a lot of stress and anxiety on the part of the patient and the family also. Do you agree, Dr. Mahesh? Am I being helpful to you as of now?
Yes, ma'am. Actually, I think for this communication skill, it needs lot of effort and lot of exercises. Hello.
Right. Absolutely, you're so right. You'll definitely to practice it more with your patients, and I'm sure everybody has their own skills of breaking bad news. Um, we do follow the same protocol, but we have our own way of getting things understood and getting things done. So you will also find your own protocol. You will also have your own way to be there, and you will be the sole owner of that particular protocol. That is my personal experience till now.
Also,
Okay.
ma'am, if I may add, can I just say something?
Personally, yes, ma'am. Yeah.
Please, Dr. Bijli.
Oh, no. Yes, I was just thinking, once one builds that rapport with the patient, then you break that bad news to every patient is also slightly different. I mean, you sort of tend to gauge what the patient is thinking, and I think that makes it easier that
Yes.
what's kind of going on in his mind, and accordingly you choose your words carefully.
Yes. So, as I said, the principles of breaking bad news or communicating bad news will always remain the same. So, need to find out whether the patient wants to know something at all or not. There'll be many patients would. So, there's a ethical question here also, because sometimes we see that the patient doesn't want to know at all. He will just shut your doors. But then, what happens? Things go wrong when we start hammering the patient that no, you will have to know, because that's what communication skills is about. We have to give you the bad news. So, we'll have to figure out whether the patient wants to know this and how much he wants to know this. Those are the two main principles. And, as we have been taught about the non-disclosure or the non-disclosure model of palliative, of communication skills, we'll definitely find that, if the patient wants to know, then you say it, how much he wants to know, you find out the insight, and then you choose your words and you go ahead with so perhaps that is the best way that you can handle. And it definitely comes by practice. And be always, you anticipate errors while doing that. Perfect. We still go wrong in many cases. So also expect yourself to go wrong somewhere. So, but don't be afraid to do that, because otherwise, if you do that, then perhaps, we'll never get to practice. So, yeah. So, was that okay?
Actually, being a head and neck surgeon, we generally give the news with the biopsy report at the time of biopsy report only.
Right. Exactly.
Okay, and we don't follow these principles how much they want to know or not. So generally we go with the biopsy report and just spoke about the what type of tumor it is and what is the next protocol and what is how much time it will take and what are the complications of the surgery and what are the complications of the radiotherapy. That's all. So we are totally straightforward. So we need lot of practice and lot of time to take this how much they want to know. Very difficult for us.
I think, sir, you need to come down from the head and neck to the heart a little bit.
No, I think Dr. Mahesh, you are actually, it's also important for you to discuss about this because, you are definitely breaking a bad news, that's for sure. But, having a diagnosis of cancer, is not always bad. And if you allow me to say so, if the cancer is an early stage cancer, you can definitely add hope to it, isn't it? So it may not be as bad as it sounds. It might be a disease. And nowadays, as I have seen in my career also, there are a lot of disease modifying agents being introduced. And, people do take cancer as a very chronic type of a disease. For example, my own mother, she's a stage 2 breast cancer patient, and she was operated. She received her chemotherapy and the radiotherapy, and now she's surviving. She's surviving. So I would say that her diagnosis was a kind of a game changer in her life, because she changed as a person. She's perhaps acquired something better in her life, or the approach towards life has changed for her, for us as a family also. But then, having said this, if it's a terminal disease and it's really going to be bad, you anticipate this is going to be truly bad, then perhaps we will definitely need to be very cautious about how we break the bad news. That is my take on that. Okay. So coming to the Dr. Bijli's case presentation, I think it's a very important topic, Dr. Bijli, and maybe someday you would like to visit this patient and see for yourself what's happening.
She's happy. And she doesn't.
Your voice is breaking.
And, is it better now?
Yes, we can hear you. No, we can't hear you.
Hello.
We can't hear you.
Bijli ma'am, whenever you are talking with for my case, your voice is clear. Whenever you're talking this case, your own case, the voice is not clear.
Okay. That is something very funny. Hello?
Yes.
Okay. So in Dr. Bijli's case, I think we have had the inputs from both Dr. Mahesh and Dr. Vinay. I would like to put forward my approach to this patient. So you see, I again would like to give importance to the kind of approach that we will do for this patient. The approach towards any palliative care patient is very important. You'll need to first, study the case properly, and then decide on how you approach this patient. Now, if this is a patient of, ALS, which is definitely amyotrophic lateral sclerosis, I would actually think about all the symptomatology that this patient might be having, okay? Irrespective of what the patient is telling you. That is definitely an important part. But then, having said that, we will need to revisit this particular, the symptoms of, the symptomatology of this particular patient, of a ALS patient. So, as we can see, um, mainly, if I am right in my approach, I would actually think of two things. One is a direct approach, another, a direct, consequence on the patient because of the disease, and another would be an indirect consequence, like, for example, if I say direct consequence, that would be totally because of the symptoms that will come because of the motor neuron degeneration, so to say. Or indirectly, if I can say, then maybe the symptoms that are a consequence of the direct symptoms. If I'm okay with, I mean, if you can understand what I'm actually trying to say. So when we see motor neuron disease in ALS, we can think about muscle weakness, muscle atrophy, then a lot of spasticity, muscle cramps. There'll be dysphagia, which is actually happening to this patient, I think, because of which the patient is, if I can remember the case, is tracheostomized also. And then we can actually think about dyspnea of this patient. Dyspnea is a very important symptom in ALS. It comes generally in the terminal stage. Also, a lot of, dysarthria. I mean, the bone pains. That is also very important. And then, of course, if we can think about the indirect consequences, those may be all the kind of psychological disturbances, the anxiety that the patient is having, a lot of sleep disturbance, a lot of sleep disturbance actually. And then constipation. Constipation is a very, very rampant symptom in ALS patient. Even in your case, Dr. Mahesh's case, the quadriplegic patient, you can actually anticipate a lot of constipation. You might have to manage constipation on a day-to-day basis, regularizing the laxatives and all. So that is one. And then Dr. Bijli's patient has a lot of secretions. The secretions are also, they are difficult to manage. They're very thick mucus secretions. That is why, you were talking about the mucinex or the acetylcysteine. I'll come to that particular point. And then because of weakness of the respiratory muscles, there'll be some kind of, you should anticipate some kind of hypoventilation also. The patient may not be able to properly do the respiratory exercise. Those are the conditions that are important. And then last but not the least, and the very important one, is the pain, which actually takes over all other symptoms that are there. So let us just think about all these things, all these symptoms, and then correlate what is happening with this particular patient, and then go ahead with the management. So when we talk about symptom control, if we have to prioritize, then let us prioritize the pain first, and then the secretions and all other things that are happening as of now. Pain, as far as I can say, pain would be totally, it would be a muscle cramp, if I can say so, and of course, a lot of musculoskeletal pain. So, the question of nocileuropathic pain is generally very less. right? So maybe, we could actually think about giving the patient some non-steroidal anti-inflammatory agents. And there are research papers. I would like to send that to Rajlakshmi, who can actually distribute those to you in email. Musculoskeletal pain is common in ALS. So I will not generally think about, neuropathic or nociceptive pain. But having said this, there might be some underlying neuropathic pain also. So I would actually suggest Dr. Bijli to perhaps start with an SAID, and then for spasticity, if the patient has spasticity, which I'm sure the patient has, you can think about something called the baclofen tablet. So baclofen is a muscle relaxant. You have to be a little careful when you use baclofen, because it further reduces, it causes actually hypotension. So maybe you can start with very low doses, like 5 mg twice a day, and then increase that up to 10 mg. Otherwise, the permissible amount is definitely 80 mg, till 80 mg. But I haven't used 80 mg as of now. I have always uh, seen that my patients generally respond to 10 mg thrice a day after meals. So baclofen is a good, anti. You can use it for spasticity. So it gives a lot of relief. So I think your pain, the patient's pain could be reduced by usage of NSAID and baclofen, if it is, there. Um, then, of course, the secretions that you told about. And we generally use, as a rule of thumb, glycopyrrolate. That is an important medication. You can use zero point 0.1 to zero point 0.2, yes, 0.1 to 0.2 milligrams of glycopyrrolate subcutaneous. Even IM also you can use thrice a day, would be in 24 hours. That could be a good thing for drooling or for secretions. Um, Nebulization is one part which you can look into for secretions to melt down also. Uh, Uses of N-acetylcysteine doesn't have much support from the research papers. And I haven't actually tried using N-acetylcysteine. So maybe you could look into more into the literature about, the importance or the usage of N-acetylcysteine in ALS. That it generally doesn't help with the mucus secretions. Having said this, it is important for us to understand that the thick mucus secretions, will actually result from a low fluid intake, and also reduction in cuff, because that is also reduced. The cuff reflex is also gone. That is also being connected. I mean, that is also that's also a problem. So both these things combined together, the cuff reflex, the reduced cuff reflex, and the loss or the reduced fluid intake actually causes a lot of thick mucus secretions, and those are extremely difficult to handle. And acetylcysteine is, very few cases would actually respond, but generally there is no literature review that actually tells this. So kind of, what we generally, I have read about is that You can do some kind of vibration therapy to the chest, massage the patient on the back, give him some, hot fermentation on the back. That would also be helpful. And suctioning generally is helpful if the patient is tracheostomized. So you can use a suction, very light superficial suction in a very low tone for suctioning out these kind of secretions. So that is about the secretions. And psychological problems, definitely these are there. Uh, else can I think about? I can actually think about something very interesting that I read is about, the pathological laughing or crying. You can actually look into that. The patient is unable to have a control on the crying or laughing. If the patient starts laughing, keep on laughing actually. And if the patient starts crying, the patient will keep on crying. So this is a kind of a pathological thing that has happened. I can't, as of now, remember why that happens, but that's definitely because of the direct effect of the motor neuron activity, reduced activity, and generally we can actually recommend usage of amitriptyline this particular.
So I'll keep that in mind. She has not complained of it as of now.
Right. So
But
that is quite psychological. This particular thing is very, very psychological because the patient, the caregivers or the family or any other people who's visiting this patient would generally think that the patient is crying, she's sad. But that's pathological. The patient is unable to control it. And if the patient is caught laughing, then they would interpret it as the patient is actually very happy, or something similar to that. So the interpretation makes a lot of anxiety for this patient, and the psychological problems actually double at this point of time. So that's very difficult to handle. And as I can make out from your case, the patient is quite terminal. You see, so maybe
yeah, probably because when she was admitted with that breathlessness, dyspnea, so that is something that has recently developed, and that's probably not a good sign.
Yes, absolutely not a good sign. And that there definitely there is a role of subcutaneous morphine, where it can reduce
The
breathlessness.
dyspnea.
Yeah. And you can also think about usage of benzodiazepines. Benzodiazepines are a good lorazepam, as we use in a dosage of the same dose, like 0.5 to 1 milligrams. Okay. You can use these. I think that would be really good. Okay. But having said this, if you're deciding on to use morphine, subcutaneous morphine, then you'll have to be careful about respiratory depression, because the patient is anyway hypoventilated, right?
This patient has no access to morphine, so that is going to be out of the question.
Right. So yeah, but tapentadol may not be full for breathlessness. And as I said, morphine or opioids will not help this patient. Okay, so consider using NSAIDs and paracetamol. Yes, paracetamol and diclofenac can be a good combination. Ibuprofen can be a good combination. You can actually think about them, and then proceed with other medication. So yes, that is from my side. Anything else?
Can I just ask a question?
Yes, please do.
Sorry. So Dr. Sangamata, you mentioned glycopyrrolate. No? So I was under the impression that this helps if the secretions are thin. If the secretions are thick, is it still going to work?
So when I would still want to use glycopyrrolate. I would still want to use glycopyrrolate because it anyway will reduce the manufacture of the secretions. That is how it is going to reduce it. So I would actually suggest using the drug.
Both, excuse me, ma'am.
Yes.
Both the drug, both glycopyrrolate and the tryptomer, amitriptyline, both are, they will increase the chances of constipation too.
Yes. So you'll have to give a laxative also. Maybe you'll have to, perform a high up enema for such patients. Because the patient may not be able to pass stools. And where, giving a high up enema to, is the patient on Ryle's tube, Dr. Bijli?
No, that was the whole concern. No? The first question, if you see, they were unsuccessful with the Ryle's tube.
Yes.
So that's why my first question was, can they address it in a subcutaneous route, the nutrition and the pain relief?
Right. So maybe you'll have to think about, manual evacuation of the stools if they're impacted, and then think about. Do you know about high up enema?
Theoretically.
Okay, so how I do it for my patients is very simple. So I take a pediatric Ryle's tube. Okay, so that tube is actually introduced through the rectum high up to the the sigmoid colon, or maybe a little further to the sigmoid colon also, and then I connect the enema tube to the cut. I actually cut the Ryle's tube on a little distance, not introducing the whole tube through and through, but I cut it and then connect the enema tube into that. Okay, or sometimes what I do is withdraw the enema contents, the medication, into a 20 ml syringe, and then connect it with the Ryle's tube, and then push that high up into the colon. So wherever there is you suspect chronic constipation, you still suspect constipation after manual evacuation, or a or a bisacodyl suppository maybe, or a small, low enema thing, then you still suspect that there is a lot of stool mass high up there. So you do that. You introduce enema through the Ryle's tube high up into the colon, and that actually, gives a good amount of passage of stools. That helps a lot. So we've done that for our patients who are bedridden. Sorry. So does that help in your?
Absolutely. But my first question is still not. I'd really like to know about that. Can we use in these patients? Like I don't know how long she is going to survive. Yeah. But on a long-term basis, can we give her? Can we maintain her nutrition the subcutaneous route?
The nutrition through subcutaneous route, I haven't really come across anything like that, because if we use total parenteral nutrition in these patients, then that will be definitely through a central line, isn't it?
Right.
That is quite invasive.
No, so maybe my question is wrong. Then I am referring to fluid balance.
This is a
considering nutrition.
ethical question, Dr. Bijli.
Hmm.
That's a very ethical question, and we'll have to, measure the benefits to the kind of um, uh, uh, ill effects that might happen because of this.
Because of the subcutaneous route, is that what you?
Subcutaneous route, I have never come across, nutrition being given through subcutaneous route. Actually, it is always through, the central line or the peripheral parenteral nutrition.
Hmm. And ma'am, what about the pain relief? No, like we are talking about giving her all these
So
tablets now. If she doesn't have a Riles tube, then uh, how does one give
yes,
so many by injections daily?
yes, you can use injections. You can also, there are patches available.
Hmm.
The NSAID patches,
Yeah, diclofenac patches. Okay, yeah, that.
can
Hmm.
use those. But
Hmm.
you have to then use a gastroprotective agent also at that point of time.
Hmm.
Okay.
Hmm. Hmm.
So yeah, the principles of
Right.
treatment would remain the same.
Hmm.
Is in-
Because she was very concerned that they're not able to get the Riles tube in, and because she's been hospitalized so many times, they're now not really able to find veins.
Yeah.
So I guess the central line is what they have to do now.
Mhm. If they do a central line, then maybe TPN. Uh,
Hmm.
but yeah, you know, it's very difficult for the family to accept that uh, these things may not be working at all. Perhaps, a simple DNS or, just to maintain her hydration,
Hmm.
be everything, because, there, you can expect actually a respiratory failure very soon,
Hmm.
because of respiratory muscle weaknesses and diaphragmatic weakness, and all these things are complications and of
Hmm.
main disease, and uh, it will be. I would generally will not recommend the central line at this point of time.
Okay.
Okay, nutrition could have been done much earlier, through perhaps a peg tube,
Take two. Hmm.
which was perhaps not done because of certain other situational problems at that point of time. But
Hmm.
those are, uh, yeah, I think it's a it's a difficult phase both for the physician and the family and the patient, right?
Right.
Yeah. But I want you to be very strong support, and I'm
Hmm.
sure. Uh, See, sometimes, as Rajgopal sir had always stressed upon, your presence is extremely therapeutic.
Hmm.
And that is what we need to do with these patients.
Absolutely, because when I spoke to her, that's the first thing she said to me. She said, "Ma'am, it is so good just to be able to talk to somebody about the problems that my mother is facing. Because I cannot even speak to the physician. They come, they give a medicine, and they go off.
Yes,
Nobody listens."
yes, yes. I think, physicians, because we are not trained to listen to our failures, isn't it?
Right?
We can't hear a patient saying that, what to do now, and
Hmm.
we don't have that answer, and we don't want to face that particular phase of not answering to the patient.
Right.
It's important that we listen to the patient. We just share the sorrow that the patient is going through. And that gives a lot of strength, actually. I have experienced this so much in my whole career till now. And it works wonders because they will not go to any other doctor at all at that point of time. They'll just need you. And they also know that, nothing is now, going to work or maybe possible, but the presence of this particular person in this phase of my life will actually give me a lot of relief psychologically. So I think that is what needs to be done, Dr. Bijli. And you're doing a great job. I mean, talking to the patient, finding out all her concerns. Yes, I think that's very important.
Thank you so much for your inputs, ma'am. It's been a great help to me. And to everybody else, so thank you so much, everybody else, Dr. Vinay, Dr. Mahesh.
I'm always available on phone. You can surely discuss, if you have any problems with managing this patient, definitely call me. I'm just a phone call.
Thank you. Yeah, I'll speak with her and then get back to you if required.
And we would like,
Thank you.
Perhaps later on, like to hear about, how you managed this patient and what was the other things that mattered. Okay.
Right.
Even Dr. Mahesh is, you also, I think you're going through a lot of stress with this particular patient. So I wish you all the best. And but
Thank you.
I think today's discussions were really, really very important. And, after getting Dr. Bijli's case, actually, I've gone through the literature. Little it was information, but then I had to revisit the literature again so that I can answer your questions. And but then I will surely encourage you all to please go through the literature. There are a lot of papers out there. Please go through a few of them. You'll have a great insight about these diseases and how to handle them. Okay. Next time, maybe Dr. Vinay, will you be able to present the case for us? Dr. Vinay?
One case I have already sent, ma'am.
Oh, okay. Okay, that's
There is one case, other I will prepare another case also.
no, I think one case from your side, and we'll request Dr. Dam Kumari this time to present. Thank you so much, every one of you, for participating, and this has been really nice, a great learning experience for me also, because I am also, to be very frank,